This is Heidi Sawyer, PharmD, and today I'll be talking about Goldilocks and bipolar disorder, getting treatment just right. Bipolar disorder is a cyclical disorder with recurrent fluctuations in mood, energy, and behavior. Patients with bipolar disorder will cycle from mania to depression, and that can include such things as hypomania, which is just a milder form of mania, depression, and mixed mood episodes. And those mixed mood episodes can include symptoms of depression and mania together, or rapidly cycling in between the two. And we'll talk about that a little bit more later. I also wanted to mention that when patients cycle from mania to depression, that cycle can be entirely patient dependent. Patients may have several episodes of depression followed by mania, or they may go back and forth between mania and depression, and hopefully they will have episodes of normal mood in between the mania and depression as well. Bipolar disorder is the sixth leading cause of disability, and that is because of the high relapse rate. 37% of patients will relapse within 1 year, and up to 60% will relapse within 2 years. Bipolar disorder also is commonly misdiagnosed as unipolar depression in up to 60% of patients, and there's several reasons behind that. First off, bipolar disorder often begins with an episode of depression rather than mania, and if you haven't had any symptoms of mania, there's no reason to think of bipolar disorder. Secondly, depression is much more common than mania. Bipolar patients will typically spend only 10% of their time in a manic episode. And lastly, patients themselves may not recognize that they are undergoing an episode of mania, or especially hypomania, which is less severe. And if patients aren't aware of it and providers may not ask, then it may remain under the radar. There are several different classifications or subtypes of bipolar disorder. The first one that we're going to talk about today is bipolar disorder 1. Now, these definitions come from the DSM-5, which stands for Diagnostic and Statistical Manual of Mental Disorders, and this is published by the APA, or the American Psychiatric Association. And the DSM-5, which is the manual that we will be using definitions from today, was published in May of 2013. So bipolar 1, this disorder includes mania as its cardinal symptom. Patients may or may not also undergo depression. Depression is very common, so it is likely to happen, but really bipolar 1 depends on mania symptoms. Also wanted to mention that psychotic features are very common with bipolar 1 and can occur in up to 50% of patients. So what is mania? Mania includes elevated, expansive, or irritable mood. It needs to be present for at least a week or result in hospitalization. And severity is really the thing that you're looking for with mania. It needs to impair your normal ability to function. And that's the reason behind the hospitalizations. They're just done for patients' self-protection. And lastly, mania should not be due to any other disorders such as substance abuse or another medical condition such as hyperthyroidism or head injury. Additional symptoms of mania include inflated self-esteem or grandiosity, and this just means a hugely inflated belief in yourself and your talents. Patients will often believe that they are never in any real danger, regardless of whatever activity they're taking part in, and that can result in some pretty risky behaviors. Patients in a manic episode will have a decreased need for sleep, so they may sleep only 2 or 3 hours a night, but feel fully rested after that. Talkative, pressured speech is common, as well as racing thoughts and distractibility, especially by unimportant or irrelevant things. On the flip side, patients will also be very, very goal-directed, but what they are directing themselves towards can often be things that involve very bad judgment. So, for example, excessive spending, bad business or investment decisions are very common. What's happening during an episode of mania is largely unknown. We know very little about the underlying pathophysiology of the disease. We have some ideas, but these are really just in the very beginning stages of being understood. Researchers believe that mania may be linked to glutamate overactivity. There's some thought that mania can be related to demyelination in the brain, and that excessive dopamine or fluctuations in cortisol and thyroid hormones may also be involved. Sleep deprivation can be linked back into all of these things too and may be a trigger for mania. But like I said, very little is known about what actually happens in the body during manic episodes, and this makes treatment very difficult because we don't really have a pharmacologic target. So it's difficult to design drugs for bipolar disorder because we don't really know what we're after. And if you'll notice later when we're talking about treatments, most all of the treatments for bipolar disorder have been borrowed from other disease states, with the obvious exception of lithium. Bipolar disorder 2 is a little bit different from bipolar 1. Bipolar 2 includes major depression in its definition, so patients must have episodes of major depression for bipolar 2. And secondly, patients don't undergo full-blown manic episodes. Instead, they have hypomania, which, like I mentioned before, is not quite as severe as full-blown manic episodes. Hypomania also lasts a little bit shorter. Only 4 days of symptoms are required rather than a week. Typically, hypomania occurs only 1% of the time. And many patients may actually view hypomania as something that's desirable because they like having that extra focus and energy. If you see someone who's undergoing a hypomanic episode, you would just notice that they're very involved, very busy, planning lots of things. That energy increase is noticeable to others, but it's not as severe, doesn't interfere with their ability to function in a normal way. I also wanted to touch on the definition of major depression because this is the most common mood state in bipolar disorder. Symptoms of major depression, and again this comes from the DSM-5, are that patients need to have 5 or more symptoms present for at least 2 weeks, and the symptoms need to include one or the other of the next 2 items on your slide, which is either depressed mood for most of the day or a loss of interest or pleasure in most activities. Other symptoms that are included in the DSM-5 list for major depression are listed on this slide for you. Most of these should be pretty familiar to you. It can include things like significant changes in weight, changes in sleep patterns, fatigue, loss of energy, guilt, worthlessness feelings, diminished ability to concentrate, and thoughts of suicide. Now you'll notice that several of the items on this slide are starred, and those are starred because these are much more common with bipolar depression than with unipolar depression. And those include hypersomnia, so just that desire to sleep all day long, psychomotor retardation, which means everything is slowed down, your thoughts, your speech, your actions, everything is just slowed. And then that extreme loss of energy. Patients with bipolar disorder will often describe that they don't actually realize what's happening to them when they're undergoing these episodes of bipolar depression because it seems so much more extreme than what unipolar depression may be or what they've seen other people go through. They often describe it as something physical and they'll say, I don't know what happened to me. I also wanted to talk a little bit more about mixed features. Mixed features can be either of two things. You can have a manic episode with some features of depression, or you can have a depressive episode with some features of mania. The main point is that mixed features will include 3 features from the opposite mood state. In the past, the DSM-4 required that patients meet full criteria for both mania and depression at the same time, but that's no longer the case in the DSM-5. And mixed features are actually fairly common in patients with bipolar disorder and can occur in up to 20% of patients. There's 2 more subtypes of bipolar disorder. The first is cyclothymic disorder, and this includes symptoms of hypomania, like we talked about with bipolar 2, along with depressive symptoms. So this means that patients have some symptoms of depression, but they don't meet criteria for full-blown major depression. Typically, this will occur for about 2 years in adults and 1 year in adolescents to meet the criteria for cyclothymic disorder. And the last subcategorization of bipolar disorder is bipolar disorder not otherwise specified. And this means that a patient has features of bipolar disorder but are not meeting the full-blown criteria for bipolar disorder. And the majority of patients who fall into this classification will convert to bipolar 1 or bipolar 2 within 5 years. Last of all, I wanted to mention rapid cycling. This is defined as a patient who undergoes 4 or more episodes of mania, hypomania, or depression in a single year. This occurs in about 16% of bipolar patients. And as the name implies, patients who undergo rapid cycling are more likely to have relapses into acute manic or depressive states. Now, rapid cycling may be triggered by medication use, and it's most often linked to antidepressant use. And certain kinds of antidepressants seem to be more likely associated with rapid cycling than others. TCAs are on the top of that list, and SNRIs, and that stands for serotonin norepinephrine reuptake inhibitors, also have a more common occurrence of rapid cycling. SNRIs include drugs like venlafaxine or Effexor. Steroids and Sudafed are also linked in with rapid cycling. Now we're going to talk a bit about the treatment of bipolar disorder. There are two stages of treatment. First is to acutely stabilize the patient. You want to be able to move the patient from either mania or depression to euthymia, which just means a mood state which is neither manic nor depressed. Secondly, you also have maintenance treatment, which is just the prevention of relapse and just the enhancement of a patient's ability to function in society socially and occupationally. The primary medications that are used to treat bipolar disorder include mood stabilizers such as lithium, certain antiepileptic drugs, and atypical and typical antipsychotics. And we're going to discuss some of these different treatments. I won't go into depth about each one of these individual drugs since there are just too many to cover here in this format, but I will focus on the agents that are most commonly used in bipolar disorder. Now this slide goes over all the drugs that have FDA-approved indications for bipolar disorder. If you look at the list of drugs on the left side of the slide, you'll notice that they start off with the mood stabilizers and then move into the atypical antipsychotics and then the typicals at the very end. Now I wanted to point out a couple of different things to you. First of all, most all of the drugs are approved for the treatment of mania. The big exception to that is lamotrigine or Lamictal. I also wanted to point out that there are very few drugs that have an FDA-approved indication for bipolar depression. Quetiapine is the drug that you want to remember in that category, and we'll talk about that a little bit more later. And lastly, there's just a handful of drugs that have been approved for maintenance treatment and a handful that have been studied for pediatric indications. And that's an issue because, as we talked about earlier, bipolar disorder is commonly diagnosed during the teen years. So really, we would like to see more drugs in those categories just to have more treatment options and more research behind them. So the first drug I wanted to talk about in more detail is lithium. Lithium is an inorganic cation. Its typical onset of action is 5 to 7 days after beginning a course of lithium, and you want to remember that because if you're using lithium to treat an acute episode of mania, you'll probably need another agent along with it to control symptoms during those first 5 to 7 days. Maximum effective lithium is seen at about 2 to 3 weeks out. Mechanism of action of lithium is unknown. We know that it does several different things, but we're not exactly sure how that all fits into the treatment of bipolar disorder. First off, lithium affects sodium transport, and that will come up again when we talk about adverse effects with lithium. Lithium also has effects on dopamine and glutamate and increases GABA and serotonin. Also wanted to mention that lithium is not metabolized, so that's good news for us as pharmacists. We do not need to worry about cytochrome P450 interactions with lithium. Now this slide talks about many of the different side effects that can occur with lithium and divides these into early side effects and late side effects. Early side effects include polyuria and tremor, and those two are starred because tolerance does not develop to these things over time. Other common early side effects include headache, decreased memory and concentration, weakness, lethargy, and GI upset. Late side effects include leukocytosis. Leukocytosis can result in an increase in white blood cell count by about 10 to 30%. So if you have a patient who is on lithium and you're thinking of using the white blood cell count to identify an infection, this is not a good way to go about it. You need to look at the clinical signs rather than the white blood cell count. Arrhythmias are also a common later side effect, as is weight gain. Now, weight gain is something that we will be talking about with almost all the different drugs that we will go over for bipolar depression. Weight gain happens in about 20% of patients on lithium. Typical weight gain is about 8 pounds in a year. And patients who are already obese tend to gain a little bit more weight than that. Hypothyroidism is also another common late side effect, as are some certain dermatologic effects, which are listed on your slide. And now I wanted to go into a little bit more depth about a couple of these different things, and we'll start off with the thyroid effects. Lithium is concentrated in the thyroid, and it interferes with thyroid hormone synthesis. This is a late side effect, so you would typically begin to see hypothyroidism occurring around after 18 months of therapy. Hypothyroidism is much more common in women who are on lithium than in men, about 10 times more common in women. So patients who are on lithium need to be monitored for their TSH, or thyroid stimulating hormone. But you also need to remember that changes in TSH can occur in other situations as well. So you can see fluctuations in TSH with the initiation of lithium and also with acute bipolar episodes. Lithium has several different effects on the kidneys. First off, lithium can cause something called nephrogenic diabetes insipidus, and this is because lithium inhibits the actions of the antidiuretic hormone. So I want to pause here for a minute and unpack some of these things. First off, we know that diuretics can cause water loss. So antidiuretic hormone simply means a hormone that causes water retention in the body. And because lithium opposes the antidiuretic hormone, what this ultimately means is that lithium can cause water loss. That's that polyuria that we talked about as one of the early side effects of lithium. In certain patients, this can be quite severe, and patients can have up to 3 liters of water loss per day with lithium. You can avoid this by trying to lower dose or switching to a once daily dosing if patients are dosed more frequently. Lithium can also cause just a chronic renal disease with a gradual decline in renal function and a gradual creeping up of creatinine. And there are many different risk factors for this. A couple different things to note include patients who are on other nephrotoxic drugs tend to have problems with this. Those who have had prior episodes of lithium toxicity tend to have more of this. Those with lots of polyuria tend to have more renal issues in general. Patients with hypertension and diabetes, those with longer and higher durations and dosages of lithium are all at higher risk of having chronic renal disease due to lithium. Lastly, I wanted to mention a couple of drug interactions that are due to lithium's actions in the kidneys. So we're not completely off the hook about drug interactions. The thing to remember with all of these drug interactions is that lithium acts just like sodium in the kidney. So if you think about where sodium is going, lithium is also going there as well. So patients who have issues with dehydration, patients who are taking diuretics, especially hydrochlorothiazide, and patients on NSAIDs will all have resorption of sodium and therefore reabsorption of lithium as well. NSAIDs are actually not recommended for use with patients on lithium because of this interaction. You can have pretty severe increases in lithium concentration, and because NSAIDs tend not to be taken chronically, this can be an issue because you can't adjust the dose for it. So NSAIDs can double lithium levels. The 2 exceptions to this is that aspirin and Sulindac do not cause this interaction, so those are safe options for patients who are needing an NSAID and are on lithium. ACE inhibitors can also cause an increase in lithium concentration through the same mechanism. Sodium is retained and lithium will be retained as well. The major difference here is that ACE inhibitors cause a delayed increase in lithium concentrations, and because of that, you'll want to be checking lithium concentrations for 2 months after initiating an ACE inhibitor. This next slide goes over toxicity that is seen with lithium. These toxicities are divided into mild, moderate, and severe. If you look at the list for mild toxicities, these are essentially the adverse events that we have already talked about with patients who are on therapeutic doses of lithium. Moderate lithium toxicity occurs with lithium levels between 1.5 to 2.5, And in general, this just includes a worsening of the side effects that you've seen with mild toxicity, but also includes some CNS effects, such as slurred speech, vertigo, confusion, and sedation. Severe toxicity occurs with lithium levels above 2.5 and can include cardiovascular effects as well as seizures. And these can be quite severe, leading to coma, cardiovascular collapse, and death. Now, because of all these things, lithium is classified as a narrow therapeutic index drug, which just means that small concentration changes in lithium can cause very serious toxicity. And because of this, lithium levels need to be checked frequently. When you're initiating a patient on lithium, you need to check levels as often as twice weekly. Also, if any dose changes occurs or if any interacting drugs are started or stopped, you also need to check lithium levels. Now, lithium therapeutic levels are listed on your slide. In general, you want to shoot for the lower end of that therapeutic range. So typically, you're going to want to shoot for between 0.6 to 0.8. If you have a patient who has had relapses at therapeutic doses, you can go a little bit higher, between 0.8 to 1. Typically, you're not going to go a whole lot higher than that, and that you will also see in more recent research with lithium. Lithium trials are, again, shooting for the lower end of that range, trying to avoid toxicities that we've just talked about. You want to be particularly careful in elderly patients. Elderly patients can have signs and symptoms of lithium toxicity at lower levels than other patients. So again, you want to shoot for lower therapeutic levels down to between 0.4 to 0.8. Well, how do you actually check a lithium level? The level needs to be obtained about 12 hours after the last dose and at least 5 to 7 days after a dose change. And that is just done in order to be able to get a steady state level. And if you're lucky enough to have a patient who is pretty stable and doesn't have any issues with dose changes or interacting drugs, you can monitor lithium as infrequently as every 3 to 6 months. Now I want to talk in a little bit more depth about the antipsychotics, and we'll first talk about the second generation or atypical antipsychotics. Now, probably the most important issue that you hear the most about with these drugs is metabolic syndrome. Metabolic syndrome is just a constellation of symptoms that includes things like abdominal obesity, elevated triglycerides, low HDL, hypertension, and high fasting glucose. And all of those things need to be monitored just by checking patients' glucose, lipids, blood pressure, as well as their body mass index or BMI. Now, metabolic syndrome is common in patients who have bipolar disorder, even if they're not on atypical antipsychotics. So 32% of bipolar patients without second-generation antipsychotics will have this metabolic syndrome, and that number goes up to 45% of bipolar patients who are on atypical antipsychotics will have metabolic syndrome. So this is something to keep in mind just because it's very common. Now this slide looks at comparing the different atypical antipsychotics and the common side effects that go along with them, so we can get an idea of what to expect with each of these different agents. Now, first off, weight gain in that top row, you'll see that weight gain is worst with olanzapine or Zyprexa. Typical weight gain with olanzapine is 9 pounds in 10 weeks, so that's almost a pound a week. If you compare that to risperidone, which has 1 plus sign, so a little bit less likely, patients on risperidone will typically gain about 5 pounds in 10 weeks. Now that's still severe. In general, the weight gain that you see here ties in with the severity of the metabolic effects that we just talked about. Now, if you look at the column for olanzapine, you'll notice that it tends to have more pluses in it than many of the other atypical antipsychotics. So just keep that in mind, that olanzapine tends to have more issues than some of the others, particularly with weight gain, sedation, and anticholinergic effects. Now I wanted to jump down to prolactin elevation. That's sort of in the middle of the graphic. Prolactin elevation can occur with atypicals because prolactin secretion is inhibited by dopamine, and these atypicals are dopamine receptor antagonists, and they cause a prolactin increase, and that is most common with risperidone, and it can lead to symptoms of breast enlargement in both genders and galactorrhea in women. Now, right underneath prolactin elevation is EPS, which stands for extrapyramidal symptoms. And you're probably thinking that second generation antipsychotics are supposed to have less EPS effects than is seen with typical antipsychotics or first generation, and that's the case. However, EPS can still occur with these second generation antipsychotics, so I just wanted to bring it up here as well. Now, there are many types of symptoms that can fall under EPS, and I'm not going to go into a lot of detail about it here, but in general, EPS is a constellation of symptoms related to muscular movement issues, and it can include such things as spasms of the face, the tongue, the neck, or the back, uncontrollable motions such as pacing, or involuntary movements of the face and the arms such as lip smacking or twisting around. And on the opposite extreme, EPS can also include drug-induced Parkinson's symptoms. Now lastly, I wanted to mention QT prolongation. QT prolongation is just a marker for ventricular depolarization and repolarization. Prolongation is a risk for ventricular arrhythmias, which mostly constitutes torsades, and that can lead to VFib and cardiac arrest, so that's why we take it so seriously. So if you look at that chart, you can see how long in milliseconds each drug is likely to prolong the QT interval. And if you look along that list, you can see at the very end, ziprasidone or Geodon increases the QT far more than any of the other drugs. So that's another important point to keep in mind, that ziprasidone is much more risky in terms of QT prolongation than the other agents. Now, just briefly, I wanted to talk a bit about typical antipsychotics so you can see some of these differences with the atypicals that we just talked about. Now, chlorpromazine is a typical antipsychotic that is considered low potency and does have an indication for the treatment of mania. However, it's an old drug and there are very few studies available, so you don't see it used a lot in clinical practice. Haloperidol is a high potency typical antipsychotic. It has been studied quite a bit more than chlorpromazine. However, it does not carry an official FDA indication for bipolar disorder. Now, last but not least, I wanted to talk a bit about loxapine, which is another typical antipsychotic, and I'm mentioning this because a new formulation of loxapine was approved by the FDA in December of 2012, and it is approved for the treatment of mania. Now, this new form of loxapine is available as an inhalation powder, and it has a little bit of a different inhalation technique. When you're using the inhaler, you have to check first that there is a green light that's turned on once you take the packaging off. If it's not on, the inhaler won't work. You also have to use the inhaler within 15 minutes of opening up the packaging or it won't work. And when you actually inhale with it, the inhaler will give off a flash of light, it'll make a clicking noise, and it starts to get warm. And after you use it, you have to check again to make sure that the green light has turned off, and that's how you know that the patient has successfully used the inhaler. Now, the important thing to remember about this particular inhaler is that it is associated with very severe bronchospasm, respiratory distress, and can even cause respiratory arrest. And because of that, it has a black box warning for these respiratory issues and is contraindicated in patients with COPD, asthma, or any type of wheezing. It also has a REMS program. REMS stands for Risk Evaluation and Mitigation Strategy, and because of this REMS program, loxapine in this inhaler form can only be administered in facilities that are experienced with intubation and mechanical ventilation. And once a patient is given loxapine, they need to be monitored every 15 minutes for an hour just to make sure that they're not having any respiratory difficulties. Now I wanted to talk a little bit about a couple of the different anti-epileptic drugs that are used for bipolar disorder. First off is valproic acid. Valproic acid's mechanism is probably related to enhancement of GABA neurotransmission. It does carry an FDA indication for the treatment of acute mania. It has been studied for bipolar depression and maintenance treatment as well, although it doesn't carry indications for those. Typical adverse effects with VPA include GI upset and sedation, although tolerance does develop to these. Ataxia and tremor are common. Increased LFTs occur in 11% of patients. And again, weight gain occurs. And like I said, this is something that we'll talk about with pretty much all of the drugs that we're going over here. The weight gain seen with valproic acid is more similar to what we saw with lithium and is less severe than what we see with olanzapine. Now, I've also listed a couple of drug interactions at the bottom of this slide. The important thing that I want you to remember here is that all of the AEDs we're talking about today will have drug interaction issues, and valproic acid will interact with lamotrigine as well as carbamazepine. So this is something where you want to be very aware and make sure you're checking for drug interactions. The next antiepileptic drug I'm mentioning here is lamotrigine or Lamictal, and this also carries an indication for bipolar 1 maintenance treatment in adults. And again, drug interactions are a major concern with lamotrigine. As you'll see here, lamotrigine will interact with oral contraceptives and many of the other anti-epileptic drugs on the market. So again, just think this is an anti-epileptic. We need to be aware of drug interactions. Common side effects with lamotrigine include headache, rash, and dizziness. Now, I wanted to talk a bit about that rash because there are two types of rash that can occur with lamotrigine. First off, there's benign rash that occurs in about 11% of patients. But secondly, patients with lamotrigine can develop very severe rash, including Stevens-Johnson syndrome, and this can occur in up to 0.13% of bipolar patients. Risk factors for this severe rash include concurrent use of VPA, high doses of lamotrigine, or a fast dose titration, and also pediatric patients can have more issues with this rash. Because it's very difficult to tell in the beginning stages what is going to turn into Stevens-Johnson syndrome and what is going to be just a benign rash, discontinuation of lamotrigine with any rash is recommended. And lastly, I just wanted to mention a relatively new warning that has been added to the package insert for lamotrigine, and that is for aseptic meningitis. 40 cases of aseptic meningitis were reported with lamotrigine over a 15-year span, and the symptoms were pretty typical for meningitis: headache, fever, stiff neck. Tended to occur about 2 weeks after initiation with lamotrigine, and it did come back if lamotrigine was restarted. So this is another reason to discontinue lamotrigine if you notice these symptoms. Well, we've talked about quite a few different medications that are approved for the treatment of bipolar disorder. Now the question before us is, how do we choose between these different agents? Well, first off, we're going to talk about the treatment of mania and hopefully give you a few pointers about ways to choose between these drugs. So just to review, the FDA-approved agents for the treatment of mania include lithium, valproic acid, carbamazepine, and the antipsychotics. And the specific agents are listed on your slide. Now, I wanted to talk a little bit about some study data that goes over some differences between these. The first meta-analyses listed on your slide compared the second-generation antipsychotics to lithium or valproic acid. And this meta-analyses found that the second-generation antipsychotics significantly improved mania scores, responder rates, and decreased the risk of dropout in comparison with lithium and valproic acid. Now, a second meta-analysis was much bigger, included many more studies, many more patients, and looked at the full gamut of any drug that had ever been studied for the treatment of mania. And this meta-analysis actually listed these in order of their effectiveness. So the most effective drugs found in this meta-analysis were haloperidol, risperidone, and olanzapine in that particular order. Now, haloperidol is not commonly used for the treatment of mania, and that's just because it has more severe adverse effects like we talked about before. Risk of EPS tends to be worse with typical antipsychotics than the atypicals. So risperidone and olanzapine would be the most effective with the least risk of adverse effects, and you can see that under dropouts in the bullet point below that. Olanzapine, risperidone, and quetiapine tend to have the least dropouts, which means that they tend to be better tolerated by patients. I also wanted to mention drugs which do not do well at all. They actually functioned worse than placebo, so patients did worse on these than if they had done nothing at all, and that includes lamotrigine, topiramate, and gabapentin. So avoid those drugs for the treatment of mania. A couple other points I wanted to mention when considering the treatment of mania. First off is to stop the use of antidepressants, and we'll talk about that a little bit more when we talk about the treatment of depression. But for now, just remember that if you're using an antidepressant, it can make the treatment of mania worse. So you'd want to stop antidepressants if you have a patient who has an acute manic episode. Secondly, you can consider the use of benzodiazepines, and this is partly because of their sedative effects. Many patients with mania have not slept in a long time, and if you can give them something that can help them sleep, that is going to be a huge benefit to them. Other thing that this is useful for is because benzodiazepines are very quickly effective and you can use them before other anti-manic medications have taken effect. So if you remember, lithium has that delayed onset of action. Using a benzo before lithium has become active can be very useful for patients. And then lastly, I just wanted to briefly mention ECT or electroconvulsive therapy. This is actually effective for both the treatment of acute mania and depression, but this is something that you would just consider sort of as a rapid short-term treatment for patients who really are having severe symptoms or who are not responding to their medications. Adverse effects with this can include cognitive impairment. You can see patients who have short-term memory loss, especially around the time of the ECT treatment itself. Next, I wanted to talk about agents for the treatment of bipolar depression. Antidepressants are used in 50% of patients with bipolar disease. So you would think that there would be a lot of data supporting their use, and actually that's not true at all. If you look at trial data, most of it does not show any benefit with antidepressants for bipolar depression. There was a large meta-analysis that included 15 trials and over 2,000 patients that found no clinical benefit with using antidepressants. So there was no difference in depression rating scores, there was no difference in remission rates between antidepressants and placebo. Trials with specific antidepressants have found similar results. Paroxetine has 2 trials that look at it as a monotherapy and also several trials that look at it as an adjunctive therapy with lithium. None of them show any benefit in comparison with placebo. Now, I wanted to mention one trial in particular because it is one of the best trials that we have in bipolar disorder, and that is the STEP-BD trial. STEP-BD stands for Systematic Treatment Enhancement Program for Bipolar Disorder, and this trial was funded by the NIMH, the National Institute of Mental Health, and included over 4,000 patients and went on for 7 years. And this is considered a real-world trial, which just means that patients also had lots of other comorbidities going on at the same time as their bipolar disorder. And so it's more similar to what you would see in a real-world practice as opposed to the very controlled setting of a clinical trial. Now, one arm of the STEP-BD trial looked at using adjunctive paroxetine or bupropion in comparison with placebo as an add-on to lithium or valproic acid in bipolar depression. And this study, like all the others that we've talked about, found no difference in remission rates with depression and found no difference when the antidepressant was discontinued. So really no effect with it. Now, in contrast to all of these trials that we've just talked about, data with the combination of olanzapine and fluoxetine has shown to be effective, more effective than placebo and more effective than olanzapine alone. And you may recognize this combination. It is marketed as the drug Symbyax. So that is the one exception where we do see a benefit with an antidepressant. Now, not only do antidepressants not work well, but there are issues with adverse effects with antidepressants as well in bipolar depression. And the biggest risk with these agents is the risk of switching a patient from depression to mania or switching them into rapid cycling. Now, this switching is much more common with bipolar 1 patients than bipolar 2 patients. And the risk of switching tends to occur more commonly with certain types of antidepressants. So if you look at this list here on your slide, bupropion and the SSRIs tend to have the lowest risk of switching, but the risk with these agents is still between 5 to 10%. Venlafaxine and the SNRIs, that's the serotonin norepinephrine reuptake inhibitors, have a slightly increased risk up to 29%, and TCAs tricyclic antidepressants, have a risk of up to 43%. Well, based on this information, the ISBD, which stands for International Society for Bipolar Disorder, published antidepressant guidelines, and they recommended certain situations where antidepressant use is recommended and situations where antidepressant use is to be avoided. So use is recommended in patients who have a history of a positive response to an antidepressant before, and for patients who have had issues with relapse into depression when an antidepressant is stopped. So those are the two situations that really want to tip you off to think, if this has worked well for patients before, we should do it again. And that last bullet point under use recommended, the guidelines recommend use of TCAs and SNRIs as a second-line antidepressant. So that means you want to consider bupropion and the SSRIs as your first choice if you're going to start an antidepressant for bipolar depression. Now, situations to avoid use of antidepressants would essentially be with patients who have mixed features, so that's that combination of both manic and depressive features going on at the same time, or patients who have rapid cycling or a history of rapid cycling. Those are patients where you really want to avoid an antidepressant because of that risk of switching. And the other main category where you want to avoid the use of antidepressants is you never want to use antidepressants as monotherapy with a bipolar 1 patient, because bipolar 1 patients tend to have much higher risk of switching, and if you use an antidepressant as monotherapy, that risk again is increased. So no monotherapy with bipolar 1 patients. So if antidepressants are not a great agent for bipolar depression, what else can we consider? Well, this slide lists the drugs that actually do have an FDA indication for bipolar depression, and those are quetiapine, lurasidone, and the combination of olanzapine and fluoxetine. And there is actual trial data to back some of this stuff up. There was a very large meta-analysis of 19 trials for bipolar depression, and again, this meta-analysis ranked drugs as most effective and so on, and the most effective drugs for bipolar depression were quetiapine and the combo of olanzapine fluoxetine. Quetiapine actually has some of the largest body of trial data supporting its use for bipolar depression, and we have trial data that shows that it is more effective than placebo, lithium, and paroxetine. And I wanted to point out again drugs that are no different in efficacy from placebo, and those include lamotrigine, aripiprazole, and lithium. So if you remember, lithium is actually quite effective for the treatment of mania, but it is not as good for bipolar depression, so that's something to keep in mind. Now, I listed lurasidone or Latuda at the bottom of this slide simply because it was not included in the meta-analyses, and it does carry an FDA indication. It has been studied both as monotherapy and as adjunctive therapy for bipolar depression, only in comparison with placebo. Now I wanted to talk a bit about maintenance treatment. There are several different agents that are approved for maintenance treatment, and lithium is at the top of that list. It has some of the best trial data behind it and has the most long-term evidence that we have for its effectiveness. And I just picked one of the many meta-analyses out there that are available for lithium for maintenance treatment. And in this particular meta-analysis, it was compared to placebo. And the meta-analyses found that lithium decreased the risk of manic relapse by 38% in comparison to placebo, and that was a significant difference. Risk of depression relapse decreased by 28%, and that was just missed significance. The p-value is 0.06. So you can see again from this trial that lithium is more effective for prevention of mania than it is for depression, and that fits right in with the data that we've already talked about. Now, one important thing to think about with lithium is that there is some data behind it that supports it decreasing the risk of suicide. And this is a very significant point in bipolar disorder because suicide is such a common issue in bipolar patients. Between 25 to 50% of bipolar patients will attempt suicide, and approximately 10% are actually successful. So this is a very serious issue to consider. Now, lithium meta-analyses have found that lithium will decrease the risk of suicide by approximately 60% in comparison with placebo. Now, if you compare lithium to other active treatments, the difference was only significant in comparison to carbamazepine. Next drug for maintenance treatment is valproic acid. Valproic acid has been quite commonly used for maintenance in bipolar disorder. However, there is very little data in long-term prevention. There's essentially 2 studies. In general, the study data has found that valproic acid is more effective for depression than for mania. So that's kind of the opposite from what we saw with lithium. And I've listed on this slide the larger and better controlled of the 2 valproic acid maintenance trials that we have available. And you can see from this trial that it was compared directly to lithium, and that lithium was found to be more effective than valproic acid. And if you use combination treatment of lithium with valproic acid, it was more effective than valproic acid alone, but it wasn't more effective than lithium alone. So really, it seems that based on this trial, there is a more limited use for valproic acid, and even as combination therapy doesn't appear to be a large benefit from this drug. Lamotrigine is our next agent, which is FDA indicated for maintenance only. This agent is not FDA indicated for acute treatment of mania or depression. But as a maintenance agent, it appears to be more effective for preventing depression relapse than for mania relapse. There was one trial that included lamotrigine, lithium, and placebo. The trial unfortunately did not directly compare lamotrigine to lithium. Both active treatments were only compared to placebo. But what we can see from this trial is that lamotrigine was more effective than placebo. It had a 36% decrease in relapse. And lastly, that lamotrigine was more effective for depression than for placebo. More effective for depression than for mania. The lithium arm of this trial was more effective for mania control than placebo, but lamotrigine was not. Antipsychotic agents are also used and indicated for maintenance treatment. The FDA-approved agents are listed here on this slide. As monotherapy agents, risperidone is indicated, but only as a long-acting injection. Aripiprazole and olanzapine are also indicated as monotherapy for maintenance. FDA-approved adjunctive agents include quetiapine and ziprasidone. Now, I just wanted to jump back to olanzapine just a second. Olanzapine really has some of the best data behind it of any of the second-generation antipsychotics for maintenance use. It has been compared to lithium and valproic acid and found to be just as effective when you're considering maintenance treatments overall. And if you're looking purely at risk of relapse for mania, olanzapine was actually more effective than lithium and more effective than valproic acid. Now, in general, these second-generation antipsychotics are more effective for the prevention of mania. So that's just what we said about olanzapine, and that is true for most all the agents in the class, with one exception, and that is quetiapine. Quetiapine is effective for depression and mania prevention, and that is different from the other second-generation antipsychotics. Now, we've talked about a lot of drugs for maintenance treatment, so I wanted to just give you a basic overview of the information that we have. So, agents that are best for prevention of mania include lithium and the antipsychotics, particularly olanzapine. Agents that are best for the prevention of depression as a maintenance drug would include quetiapine and lamotrigine. Valproic acid has also been studied, but isn't probably as effective as the others, although we are lacking direct head-to-head trials to show that in comparison with lamotrigine and quetiapine. Now I wanted to talk a bit about psychotherapy. Psychotherapy focuses on educating patients and caregivers, looking at ways to reduce stress, signs of recurrence, to maintain a healthy lifestyle in terms of getting regular sleep, exercise, and nutrition, and improving adherence with drug therapy. There are several different evidence-based methods for administering psychotherapy. The question before us is, do any of these really work, and are any of them better than the others? Well, the answer with acute mania is that patients who are undergoing an acute manic episode are not very receptive to psychotherapy, and there is little data to indicate that it's really effective at that point. However, patients who are in the maintenance phase of treatment or who are undergoing treatment for acute depression do respond well to psychotherapy. And the trial data that we have at this point indicates that there is no real difference in the various methods of psychotherapy All of them appear to be equally effective. Well, what about pharmacists and adherence? Well, up to 50% of patients with bipolar disorder are non-adherent to their treatment. And I wanted to draw attention to some of the reasons behind that. About 40% of patients feel that their medication is not needed or not wanted. And that really is a point where pharmacists can jump in and really counsel patients and help them to understand why they may need their medications, why they're undergoing some adverse effects, how long they're going to last, if it's really going to be worth it to fight through all of that. So pharmacists can contribute greatly in this area. Well, how can pharmacists do this? It's helpful sometimes to understand some of the models that go behind patient adherence or compliance. And one of these is the health beliefs model. This focuses on patient beliefs and how they impact behavior, in our case, compliance with medications. And the health beliefs model looks at a patient's beliefs about susceptibility, which means do they really think they're going to get this particular illness or this particular adverse event? How severe do they think their disease is going to be? What are some of the reasons that they see as barriers to compliance? Why would they stop taking their medications? What's really behind some of that? And then some of the benefits. Do they really understand how well their medication is going to work for them? So as pharmacists, if we can focus on addressing some of these issues, we can make a bigger impact on patients' adherence. Now this last slide goes over some different interventions that have been studied and have been published that pharmacists have done in order to improve counseling in bipolar patients. And these are sort of divided into different types of practice settings. So in the community setting, pharmacists have studied doing extra education with New Start patients, giving extra information on adherence, whether that is verbal, written, or even in video format. Pharmacists have looked at mailing out refill reminders to patients just as that extra cue to get them to get over a barrier to compliance to refill their medications. And pharmacists have also studied notifying providers if medications are not picked up within about 7 to 10 days. Now, if you're in an outpatient clinic, HMO, or a VA setting, pharmacists in those settings have studied additional interventions, including such things as having regular pharmacist intervention, whether that's by telephone or in person, doing pharmacist med reviews, doing formalized clinical monitoring of patients, and also doing unit of use or unit dose packaging, which can just provide that very concrete reminder to patients whether or not they've taken their medication for the day. Now, of course, we realize that these are only just ideas and they may or may not even be possible in your particular practice setting, but hopefully these ideas will help you to think creatively about how to better counsel bipolar patients. And with that, I'll wrap up the presentation.